Good morning. This is wonderful to see this room filled with our SAGES members and friends and guests. And it is my privilege to introduce Dr. Brian Dunkin this morning. He is well known as truly embodying SAGES, and he warmly embraces SAGES in a very heartfelt fashion and loves SAGES as so many of us genuinely do. Well, getting to know Brian, who grew up in Wisconsin just outside of Milwaukee, he learned to embrace things that he loved at a very early age. He also picked out a tire that seemed to be an early indicator that someday he might live in Texas. Well, he also seemed to know at an early age what his career path would be as a surgeon, and he started training, in this case in neatness. And he had two older brothers that placed him at the back of the bathtub, but he sees this as an opportunity to explore team training. He also had a little sister who he mentored in instrument handling with whatever instruments he might have available to him. Well, he also had a sense of strong character development, and I wonder what might have been going through his mind at this phase of his life. He learned how to pose for pictures, and certainly has done a good job with that. He also learned how to dress really sharp, and if you're wondering which one he is, it has the little SAGES emblem in front of Brian. He always gave his mom lots of hugs and had a terrific upbringing. Well, when he was 14 years old, they moved to Las Vegas. And that's where I think his formative years were, finding his inner strength through football and other sports. And he really grew up to be quite the professional individual. He then moved on to study engineering at Boston University. And I think that has given him a lot of his keen insights and analytical thinking. He then went to medical school at the University of Nevada in Reno. And Brian had actually his own set of unique learning objectives. First, to get his degree, and second, to meet Annie, who would be his future wife. Well, he had to think about this one for a minute, about how exactly he was going to win this bright, talented young lady over. And he thought about self-images, and he thought for a minute, but somehow this really just didn't fit. So he looked towards other role models, other styles, and ultimately he developed his own style, and fortunately it was successful, and he won Annie over. Well, he continued his training at the George Washington University with Barbara Bass. Again, the SAGES emblem gives you an indicator of which one Brian is. And he took a couple of years off to study cell proliferation and nitric oxide effects on visceral blood flow. And further developed his analytical thinking skills in surgery. We all know and love Jeff Ponsky, a true pioneer in endoscopy, and this is where Brian went next to seek out his training to be a world-class endoscopist, to embrace this technology not only lifelong in his clinical practice, but importantly to teach others, in this example through simulation and the famed Dunkin operation game. He also has an affinity for sushi and chopsticks, and thanks to Bob Robersi for helping me on that slide. It's something that he has embraced lifelong in his career as an MIS surgeon, first at the University of Maryland, then at the University of Miami, and now at the Methodist Hospital in Houston. Well, Brian has done a tremendous amount of work in his career, especially as it pertains to his current institution, building this world-class research and education institute called MIGHTY, training hundreds of surgeons annually through the endeavors that he puts on there. He's also always at the cutting edge of technology and has rejuvenated SAGES efforts around telementoring and should be applauded for those efforts. Well, he also has hobbies that have lasted through his days on the beach, then out at the ocean, and then he loves his motorbike and has this wild spirit, I think, on that bike. He's done a fantastic job sharing with us his tremendous love for his family, shown here with Annie and their children, Joey and Megan. He's traveled the world with Annie to all sorts of destinations. He has always had a special spot in his heart for his mother, Rita, who is now 81, and his children have grown up to be fantastic individuals and now are teenagers. Well, at the SAGES family, he embodies excellence and has been awarded not only in this organization but in others for his relentless pursuits. And as this t-shirt says, he will work for SAGES. And indeed, he has and does. He can put his head to the grindstone and get some serious work done. He also takes a break every once in a while at one of his favorite shops that somehow has a similar name to his family name, but no relation. And he'll recharge his batteries a little bit and then bring exuberance and positivity to our executive committee time and time again. He also has done a great job transitioning leadership between presidents, even in informal retreats in South Texas. He has also been a fantastic ambassador to our sister and brother organizations throughout the world and to all of our friends of SAGES. Well, even when the tides get high and the waters rise, as was shown here in a flash flood in Houston that happened to swallow Brian's longtime favorite Mercedes, Brian has a knack of rising above all of this turmoil and chaos, as I think we'll hear in his talk, and coming out, embracing leading-edge technology and pointing things in the right direction. So with no further ado, it is my privilege and honor to introduce our SAGES president, Dr. Brian Dunkin.
Thank you, Danny. Thank you. Well, thank you, Danny. Thank you for, maybe thank you more for not showing all the pictures that Annie sent to you for that presentation. It's always interesting to see yourself, especially when I had hair. I wanted to start off by asking how many of you last night attended the TEDx Beacon Street conference? Yeah, a lot of you. It was amazing, wasn't it? You know, I'm completely enamored with the TEDx style of presentation, a style that allows for communication and gets away from PowerPointing. And in fact, I've tried to import that style a bit into our annual meeting. Last year, we did a SAGES talk session where we piloted this idea of doing TED-style presentations, and it was nicely successful. Then I did something smart. I got people smarter than myself to run that program this year. And Steve Schweitzberg and Melina Vasiliou worked for over a year with the TEDx Beacon Street franchise to pull that together, and I thought they hit it out of the park. So I thought in that style, with that desire for communication, I'm going to move away from the podium, open the jacket a little bit, maybe take off my tie. Well, how about I just loosen it? Those of you who know me know I don't do casual very well. And I want to spend our time this morning talking about things that are important to you, important to me, and important to the world of surgery. And I want to start by sharing an event with you that happened to me in September of last year that really had a profound effect on me. I was in the operating room doing a POEM procedure, per-oral endoscopic myotomy. Many of you know this operation, but if you don't, it's a strange and wonderful operation. It's an operation done completely through the mouth of the patient, no incisions on the abdominal wall, and it's done to relieve a blockage between the esophagus and stomach that prevents these patients from being able to eat. And because you have this endoscope in the patient's mouth and tunneling in the wall of the esophagus, you see things that you're not used to seeing with an endoscope. You can see the heart beating. You can see the diaphragm moving. Sometimes you even see the left lobe of the liver. And so for me, there's a touch of anxiety associated with doing these procedures. And I'm doing the POEM procedure that morning, and it's going well. I'm happy with the progress. I'm happy with how we're moving through the operation. And then I get into bleeding. And in this operation, bleeding is an issue not just for the blood loss to the patient, but because it can obscure my view for doing the rest of the procedure safely. So it's something that you want to stop quickly. And in the heat of the moment, I'm working the endoscope, and I ask my scrub tech, and we'll call her Sandy. I say, Sandy, I need the hot biopsy forceps to stop this bleeding. And there's no response. So I look up at Sandy, and it's clear that she has no idea what I'm talking about. She doesn't know what that instrument is, and she certainly doesn't have it on the back table. So I figure, okay, well, let me talk to the circulating nurse. And I turn to talk to the circulating nurse to get the instrument, but the circulating nurse has left the room to go talk to the family and give them an update. And I figure, okay, well, I'm going to have the fellow help Sandy. The fellow's done the procedure with me before, and I remember no fellow today. This is one of the many days where I'm in the operating room with no resident or fellow. I'm working with a paid first assistant, and they've never seen this operation before. So by that time, the circulating nurse comes back to the room, and I start barking out instructions. I say, I need the hot biopsy forceps. It's in the bottom drawer of the endoscopy cart over there. It has a red shaft to it. It's peel-packed. It's got a black handle. And she finds it in the drawer, and she gives it to Sandy, and Sandy's fumbling to put the instrument together and really not figuring out how it works. And in the meantime, the bleeding continues. My heart rate's going up. So at this point, with the endoscope still in the patient's mouth, I cradle it under my arm, and I literally reach across the patient to help Sandy put the hot biopsy forceps together, connect it to the connection cord, show her a bit how the handle works, and then take it and put it down the endoscope, and I stop the bleeding. And I take a breath, irrigate things out a bit. Everything seems good, and I continue. And the rest of the operation goes well. Patient gets a great myotomy. I'm happy with the result. Has done well through the whole procedure, really no problems, hasn't needed a blood transfusion. But at the end of the case, as the patient's being transferred out to the recovery room, it's clear to me that the air has literally been sucked out of this OR. And I want to fix that. I want to have a bit of a team debrief. I want to talk about the importance of understanding the instrumentation and having it ready. I want to talk about communication and keeping each other abreast of where we are in the procedure. And the team is having none of that. They are done. They're done with this procedure, and they are done with me. And so I move on. I've got a full operating day scheduled. I need to continue to get through my cases. And that's what I do. We work through the day, we get the cases done. It's about 7:30 at night, and I'm walking out of the operating room, and I come around the corner toward the front desk, and the charge nurse in the operating room, we'll call her Jackie, comes down the hall toward me. And it's not normal for Jackie to be there that late. And she comes up to me and she says, Dr. Duncan, I need to speak with you in private, please. And she literally pulls me aside into a storeroom and closes the door off the main hall. And she says, I need to make you aware that Sandy has filed a PSN about you. I didn't know what a PSN was. And when I asked, Jackie says, well, that's a patient safety notification. That means that Sandy believes your behavior in the operating room today compromised patient care. And I was devastated. I was confused. I was angry. I was embarrassed. You see, I love surgery. I love teams in surgery. I went into surgery because I liked watching groups of experts come together as a team and do things together better than they could do by themselves. I wanted to be part of that team. And that's why I went into surgery. And I lost my team. And so I asked Jackie, I said, well, what do we do? What does this mean? And she said, well, we have to come up with a plan on how we're going to fix this. And starting with a meeting that we're going to have on Monday with you, me, and Sandy and we'll come up with a plan. This was Friday. So I had all weekend to kind of stew about this. And I got to tell you, it really set me back. It made me think about a lot of the challenges that we have in surgery and the frustrations, all the things that slowly eat away at our soul in this profession and make us lose our commitment. And I really was thinking about my role in the world of surgery. And then I started to think about opportunities. Where are the opportunities? Where's the good stuff? And I started to think about all the opportunities I've had in this world of surgery. And one of the best opportunities, one of the most amazing opportunities I've had is to be president of this organization for the last year. And that opportunity has given me a vantage point to see things into the world of surgery that I want to share with you this morning. And so I want to talk about three things. I want to talk about surgical training, I want to talk about quality in surgery, and I want to talk about barriers to practicing surgery. And then we're going to come back a bit to teams. So let's talk about surgical training. How many of you in the audience believe that surgical residents graduating from residency today are less well suited to go into independent practice than you were when you finished your surgical training? Raise your hand. Yeah, it's by far the majority of you. You know, we did a survey among surgical trainers in the state of Texas, my home state, and they said the same thing. But then we asked them a parallel question. We said, well, how many of you think that fourth-year medical students going into residency are less well qualified than you were when you started your residency? And you know what they said? They said they're every bit as good. In fact, we think they're better. Well, if you're starting with good stuff and you're not ending with good stuff, we got a problem in the middle. That's our problem. So what's being done about that? Well, I have to tell you, from this vantage point, I have seen activity in restructuring surgical training in a way that I haven't seen before. The American Board of Surgery is having directed specific discussions and workings on reformulating surgical training in this country in a way that I haven't heard about in the past. Our representation, two past presidents represent this society to the board. And a few things that are being talked about. They want to restructure surgical training into a 4+ paradigm. 4 basic years of surgical training, and then plus 1 or 2 years of additional training to go into your area of specialty. And if you're not sure about that, think about this. In June of this year, your fourth-year surgery residents who are getting ready to become chief residents will be given the opportunity to take their written board exam. That's in alignment with a 4+ paradigm. The American Board of Surgery has also petitioned the American Board of Medical Specialties for the right to offer a certificate of focused expertise to graduates of non-ACGME fellowships. What does that mean? What's a non-ACGME fellowship? Well, think about minimally invasive surgery, bariatric surgery, flexible endoscopy, the things that we do, that's non-ACGME fellowships. So to have the board involved in certifying those fellows gives us an opportunity to rethink advanced surgical training and to do it better by adopting best practice. These are opportunities that we have. So what's SAGES doing about that? Well, first of all, we fully supported the idea of certificates of focused expertise from the American Board of Surgery. We wrote to the board saying so. We wrote to the American Board of Medical Specialties and said so as well. We're working with the Fellowship Council, which is the oversight body for credentialing non-ACGME fellowships, a body that was formed out of this organization, and helping them to recraft curricula and credentials to align with a more effective advanced training. We're partnering with other societies like SSAT to define what that advanced training might look like. And we've written a white paper that codifies our ideas on what advanced surgical training should look like, how it incorporates best practice, and we will get that published in our journal in the near future. Well, training doesn't stop at residency and fellowship. What happens when you and I go into practice? Let me introduce you to this man. This is Buckminster Fuller, otherwise known as Bucky to his friends. Bucky was a really interesting guy. He was a scientist, an architect, and a writer. In fact, Bucky invented the geodesic dome. He's the guy who the buckyball has been named after. That's the backbone of nanotechnology. And one of the things that Bucky described was the knowledge doubling curve. And he observed that all human knowledge in the world was doubling at a rate of about once every 100 years, up until World War I. By the end of World War II, it had accelerated to every 25 years. As we sit and stand in this auditorium today, all human knowledge about medicine is doubling every 18 months. What does that mean? That means that when you go into practice, you better be ready to retool and retrain multiple times through your career if you want to stay abreast of your field. The problem is we got no infrastructure to do that. When I wanted to learn poem, there was no place to go and learn poem. I had to do that on my own. I flew to Japan and watched Professor Inoue do the operation, who's in the audience today. I then had him come back to my institution and coach me in an animal laboratory preparing for clinical experience. And the first time I did a poem in the operating room, I called my friend and colleague Jeff Marks and had him fly to Houston to mentor me through the early part of my learning curve in the OR. We need to do this better. We need an infrastructure. So let me tell you about a few opportunities. If you signed up for the postgraduate course in abdominal wall reconstruction at this meeting, you were given the opportunity to participate in Project Adopt. Project Adopt is changing our postgraduate courses, moving them away from an episodic one-time event into a longitudinal learning curve with multiple touch points over a 12-month period of time that is more effective in getting you to adopt a new technique or new technology and giving you the support that you need. What else? This society is 35 years old this year. Over 35 years, we have been accumulating educational material. That is a mountain of stuff. That is so much stuff that we're having trouble cataloging and accessing it. So what did we do? We hired a librarian. I think we're the only surgical society on the planet that has a full-time librarian. And librarians today aren't like the librarians when I was in high school with the Dewey Decimal System and card files. They are experts at cataloging and accessing information. And they're taking that 35 years of stuff and making it accessible to us. And we're using it to create powerful curricula. So Dr. Danny Scott, our president-elect, and Dr. Dan Jones, our first vice president, have formed a curriculum task force that is defining curricula to competency, proficiency, and mastery for practicing surgeons to help them learn new techniques and new technology and stay abreast of their field. What else are we doing? We need to do surgical training better for practicing surgeons. Dr. Scott showed a shot of Mighty, our education and research institute in Houston, and I have to correct him, by the way. We train thousands of clinicians a year, not hundreds. But I train a lot of surgeons in the hands-on lab, and I get them feeling pretty good about this new procedure or this new technology that we're introducing, and then I send them home, and they feel like this, right? You're alone in the operating room. And it's left to your own devices to introduce POEM or whatever the new procedure is. And surgeons don't like complications, and they will not move to adopt that new technology if they don't feel confident in doing it. We need to be there. We need Jeff Marks in everybody's operating room to help them through the early part of their learning curve. And we can do that not by flying experts all around, but by leveraging technology. That is telementoring. That's using modern audio-video communication to give you a presence in your operating room to help you through the early part of your learning curve. That's how we're going to get meaningful procedural adoption. So we've formed a task force within this society, a telementoring task force, led by Doctors Schlachta, Ninh Nguyen, and Todd Ponsky, to define what this field is and use the strength of this society to push it forward. Last summer, they held a Project 6 Summit, we called it, a telementoring summit, brought 50 stakeholders into a room, had them define what telementoring is in the surgical space, identify what the barriers are to practice, and then strategize about how we're going to overcome those barriers. An amazing white paper codifying that has been written and will be published soon. You'll see a series of papers coming out of this. And this group is working wholeheartedly on the first major challenge, and that is the legal and regulatory hurdles that keep us from being able to leverage this technology. Our goal is to get communication into all of our operating rooms so that we have the support that we want when we're bringing new techniques and technologies to our patients. Number 2, quality in surgery. Everybody's talking about quality in surgery, aren't they? Everybody wants a healthcare system that delivers high-quality care to our patients and does it efficiently. And there are lots of activity to do that. In fact, this year, in 2016, Medicare and Medicaid in this country are linking 85% of what they pay you and me to do to care for patients to some type of metric of performance. The problem is they don't know how to measure quality. In fact, they know that. They come to societies like SAGES and they say, you help us measure quality. Tell us what's important to measure, and we'll build that into our incentives. SAGES has not traditionally played in the quality landscape. And so we need to get a maturity in this area in order to advocate for you. If you and I are going to be measured by the quality of the work that we do, we have to have a say in what that measure is. So we've energized our quality committee to attack this issue and to give us a maturity in this space that will allow us to have a say in how we're going to be measured. We had a summit in the spring, a quality summit. We had Blue Cross Blue Shield, Kaiser Permanente, CMS, National Quality Forum, different societies, the Society of Thoracic Surgery, ASGE, come into the room, spend 2 days with us, and talk to us about what it is they're trying to do in quality. And we've used that summit to drive our strategy. Part of that strategy is getting recognized on a national stage for having an interest in this area. So we joined the National Quality Forum. We have representation to this body. We have members working on committees. We're attending their annual meeting, and we're establishing a recognition of this society as being an important society in the quality landscape. We're also partnering with other societies. We're in discussions with the America's Hernia Society about expanding their work in developing a quality registry for abdominal wall reconstruction. And we're also advocating for the value of minimally invasive surgery. Let me ask you another question. How many of you get paid more to do an operation laparoscopically than you do open? Not one hand. It doesn't work that way. In fact, for the most part, we get paid less. Well, why is that? There are groups that have shown that if you do colon surgery laparoscopically versus open, controlling for all other factors, you save thousands of dollars per patient. But you have to look at the 30-day patient experience, not the operating room experience. So you're not getting credit for that 30-day experience. In fact, you're getting penalized. So over this last year, I've been spending time in front of business organizations who are self-insured, talking to them about the value of minimally invasive surgery. In front of Fortune 500 companies and their human resource and benefits managers. And they are listening, and they are motivated maybe to pay you for doing that operation laparoscopically. But they asked two questions. First question is, why can't all surgeons do it with a minimally invasive approach? And so we talked to them about the work that SAGES has always done and continues to do to help surgeons adopt the techniques and technology that we think are best for our patients. And then they ask, how do I find a surgeon who can do that? And so we have created a website through our Healthier Sooner website in SAGES that allows you to search for a SAGES surgeon. You can search it by specialty, you can search it by location to where you live, you can find a SAGES surgeon in your area. Third, barriers to practice. I hate it when a non-clinician tells me what I can and can't do for a patient. How many of you have been on a peer-to-peer call with the insurance company to try to get coverage? Yeah, a little frustrating, isn't it? The POEM patient I talked about, I had to have a peer-to-peer call with the insurance company to cover that operation. I had to spell achalasia for the peer on the other line. I'm not lying. We can't tolerate those kinds of barriers to delivering the care of our patients. We need to advocate for you and for me so that we can do the things that we know are right for our patients. And so we've done that traditionally in written word through this society, but we need to go further. We've formed an advocacy initiative within the society to take all the pieces that can potentially be used to advocate for what we want to do for our patients, organize them, and bring them together in a strong way. And we've been doing some pilot projects. About a couple of months ago, one of our industry partners approached us and said, you know, there's a company called HCSC that owns Blue Cross and Blue Shield in 5 states in this country. And they're having a meeting to talk about coverage for patients that have gastroesophageal reflux disease. Would SAGES come and talk about the surgical management of reflux? And we said, yeah, we're there. We sent Paresh Shah to talk to this group, to talk about where the surgical management of reflux fits in and where different technologies fit into that landscape. And you know what they said? They said, wow, thank you. We have never had a professional organization attend one of these meetings. We've asked, and no one's ever come. And so this is building relationships directly with the payers to be able to get them to cover the things that you and I know are right for our patients. Now, I want to get back to teams. Because that weekend that I was kind of thinking about all of this, I thought a lot about teams. Teams are what allow us to do things bigger than ourselves. And if you think about it, we have a lot of teams in our lives. I've got my home team. My wife, Annie, been married 23 years. We've lived in 7 different states together, started 13 new jobs together, raising 2 children, Joseph and Megan. Megan's here today. That's my home team, the team that supported me. I've got my work team. My surgical colleagues are fellows, and my assistant, Ann, who absolutely runs my work life. I'm not allowed to even schedule an event on my calendar without Ann approving it. She's in the front row today with our family. In fact, tonight at the gala, remind me, I'll buy you a beer and tell you the story about how Ann found my suitcase in the trunk of a taxi when I had left it there by accident, and I couldn't even tell her what color the taxi was. Then there's my mighty team, amazing team. Education and research experts run a program that educates 6,700 healthcare professionals a year. Really an amazing team. My SAGES team, the executive committee that I had the honor to work with this year, amazing people that spend a lot of time on behalf of this organization. Our program chairs, Rob Finelli and Ted Truss, who put together this amazing program that has exceeded attendance records of all prior meetings in SAGES history. Truly an amazing accomplishment. The team that backs us up, the BSC team, led by Barbara Bursey and Sally Matthews, an amazing group of individuals that do the work for us on behalf of this society. Every president that's been on this stage over the last number of years has talked about how special Barbara and Sally are. I always knew how great they were, and working with Sally, I knew how special she was, at least I thought. And then I spent this year talking to her on a weekly basis and managing the work of our society. This is a unique individual, a true special treasure for our society, and so important for the work that we do. So thank you, Sally, for the work and for the last year. I got to throw a shout out to Jason. He's my partner in crime around all things IT for our institution, responsible for that app that you're using to navigate this meeting, or maybe even to stream this talk live right now. And then there's my special team. People that I might have known all my life, that have helped shaped me and shaped my career, or people that I might not have known very long, but have made me think differently, see the world differently, be a different person. And then there's my OR team. So I came back to work on Monday, and the meeting with Jackie and Sandy isn't until 3 o'clock in the afternoon, and I'm completely distracted trying to get through my day because I'm nervous about this meeting. I'm not sure how it's going to go, and I really don't know what I'm going to say. And 3 o'clock comes around, I go down to the operating room, I knock on Jackie's door, she invites me into her small office, and she says, "Let me go get Sandy." And she brings Sandy in, and we sit down around a small conference table, closes the door, and the tension is thick in the room. Sandy won't even look at me. Nobody's quite sure where to begin, and so I start. And I start with an apology. Because no matter what I was concerned about around patient safety and communication, I never want my actions to be received as negatively as they were by Sandy. And then I start to talk a little bit about my side of the story, about how there's some anxiety for me associated with this procedure, about how important it is to understand instrumentation for it and have it ready when we need it, about communication so I know who's on our team and when they're going to be there and when they're not going to be there. And I talk about how oftentimes I feel alone in the operating room, like I'm the only person that cares for that patient. And then Sandy looks at me, and she's angry. She's angry because I did not treat her like the professional that she holds herself to be. She's angry that I would suggest that she doesn't care for that patient as much as I do. And she's angry because I set her up to fail. I didn't teach her about the instrumentation. I didn't tell her enough about the procedure and the operation. And then, slowly, we started to talk back and forth. And quickly, things get animated. All three of us are talking, and we're strategizing about how we're going to make this better. We're talking about how we're going to prepare the operating room better, how we're going to communicate about the procedure, how we're going to communicate with each other to know where we are and what we're doing, how the team is empowered to push back against me when they think I'm going in the wrong direction. And you know what? I've got my team. I've got my team back. And we're doing things in the OR better than we've ever have. And I'm having more fun in the OR than I've had in a very long time. You know, there are 41,000 surgeons in this country. That's 1.28% of the healthcare community. That's 0.13% of the US population. That is rarefied stuff. It is an honor to be a surgeon. It is a privilege to be a surgeon, and we need to revel in that privilege. We need to soak up the camaraderie of meetings like this and use it to revitalize ourselves. We need to enjoy our patients' stories and take pride in their good experience when they have it. And we need to not be distracted by challenges, but to rush at them and look for the opportunities. 2 weeks after my meeting with Sandy and Jackie, my poem patient, came back to the office. And I go into the room where she is, I close the door, and she's in tears. And they're tears of joy. Because for the first time in years, she can eat. She can eat real food. For the first time in years, she can sleep through the night without waking up in the middle of the night, gasping for air because she's throwing up. And for the first time in years, she can go out to dinner with her family and friends and enjoy a meal and the camaraderie of that meal without having to go to the bathroom to throw up. That is surgery. That's surgery. Thank you. Thank you. Thank you. Thanks, man. I hope that was all right. Thank you. Thank you. Are we looking over there?
Fabulous.
Over there.
It's your prize.
There we go.
Great.
Thank you.
Congrats.
Thank you, man. Thank you. Rob, yeah. Got to button up.
Well, I'm not sure I want to follow that. President Dunkin and SAGES, the military has a lot to be thankful for when it comes to SAGES. Basically, I liken it to the young teenager who's learning how to drive. And the first time I asked to borrow the car, they said, sure. Here are the keys. Don't get in an accident, but if you do, we'll be there to pick you up. The next time I asked to borrow the car, they gave me a new car. It was an old car, you know, imperfect, but my own car. And then next year after that, they gave me another brand new car. And because of that, the military has thrived in its separate clinical practice and as an academic, in its academic endeavors. Because of what SAGES has provided for us, we now have an educational conference for our residents that our own senior leadership couldn't provide for us for several years. Because of what SAGES provides for us, we can go off to war and do trauma surgery for 6 months, sometimes not very often during that time, and come back and get education, get leadership, get mentorship. That allows us to practice in our own practices with the comfort that SAGES is behind us in what we do. We do something very well in the military, though, and that's traditions. I was unable to come to SAGES last year. Don't feel bad for me. I got an all-expense-paid trip to the Southwest Asia. I was allowed to check on my timeshare, which I get to do every couple of years. One thing, and where I was stationed was in Kandahar. And in Kandahar in 2002, the United States military removed the Taliban from the leadership. And while the Taliban is still there in Afghanistan, it's not the same Taliban that we came to know back in the early 2000s. I won't get into the political statements about that, but what's remaining standing in Kandahar is a building called TLS, which anybody who's been deployed to Afghanistan stands for Taliban's Last Stand. And in that TLS, there's a flagpole, which an American flag was raised back in 2002, signifying the end of the Taliban regime. The tradition that we have in the military with flags is that we can retire flags and dedicate them to certain people by flying them. After we fly them, the flag is retired and it's no longer flown in houses or whatnot. It's usually done at an important event and to signify people. So last June, when I was still in Afghanistan, I flew a flag in honor of SAGES to signify how much the military appreciates all that SAGES has done for us over the years, and signifying the strong relationship we have with SAGES. So today I'd like to present to President Dunkin and to SAGES on behalf of the military members the flag that was flown in Afghanistan last June 2015.
Thank you, Rob. Thank you, man. Thank you. It's really nice. Thank you. Amazing, isn't it? Really amazing. Thank you, Rob. You clearly see the reception that this society has for the military. And if you're not aware, the military has a whole day of education that they hold for their group, but it's open to all of us. So whenever you come to a SAGES meeting, I encourage you to go to those sessions. They're really amazing to hear about and see the work that they do.